Welcome everyone to Mayo Clinic Q&A. I'm Dr. Sanj Kakar. The gallbladder is a small pear-shaped organ on the right side of the abdomen and sits just beneath the liver. It sometimes can become cancerous, and when discovered early, there is a good chance for a cure. Unfortunately, however, most gallbladder cancers are discovered at a late stage and the prognosis can be poor. Cancer can also form in the bile ducts, which are the slender tubes that carry bile fluid. This type of cancer is called cholangiocarcinoma. February is Gallbladder and Bile Duct Cancer Awareness Month, and joining us to discuss this today is Dr. Kabir Mody, who is past co-chair of the Hepatobiliary Disease Group at the Mayo Clinic Cancer Center. Welcome to the program, Dr. Mody.
Thank you so much. Pleasure to be here.
So, Dr. Mody, how common is this?
Yeah, so cholangiocarcinoma, which encompasses gallbladder cancer and bile duct cancer uniformly, is pretty uncommon. Represents only about 3% of GI cancers overall, but is one of the few cancers that is actually rising in incidence globally, and including here in the United States.
And so what causes it?
So this is caused by, as with most cancers, the bile ducts are these little slender tubes, as you said, that start in the liver, and they migrate and coalesce as they go through the liver down into one single bile duct that exits the liver, and that bile duct goes and empties into the small intestine, small bowel. And so the cholangiocarcinoma can occur anywhere along this. It occurs when these cells that line these bile ducts, called cholangiocytes, they develop changes in their genetic code. Mutations is another word for that, which change the instructions for how that cell behaves, and eventually becomes cancerous when those cells turn to growing too much. And basically what happens is it becomes a tumor within the bile duct, and then that tumor, as it progresses, will invade through the wall of the bile duct and into the liver, which is why many of these cancers, when we do find them, appear as a mass within the liver, but they're really coming from those cells that line the bile duct. And gallbladder cancer works similar. So from the lining of the gallbladder, these cells turn cancerous, and frequently, when they become more advanced, will invade through the wall of the gallbladder and up into the liver, where the gallbladder meets the liver underneath.
So are there genetic causes, or are there certain behaviors that may lead to an increased risk of these forms of cancer?
Yeah, so there are some risk factors for cholangiocarcinoma. Many of them are shared between all forms of cholangiocarcinoma. Others seem to be more specific for different subtypes, and maybe more important in some areas of the world versus the others. We know there's different incidence rates and mortality rates around the globe with geographic variations, probably because of some environmental factor, or perhaps different genetic etiologies. But in terms of risk factors, common ones would be, primary sclerosing cholangitis, which is a condition that causes hardening and narrowing of the bile ducts and a lot of inflammation. Chronic liver disease, scarring of the liver, which can be caused by chronic hepatitis, and other things, frequently known as cirrhosis. Older age, diabetes, smoking, obesity, and in some areas of the world, there are parasites which infect and live in the bile ducts that cause significant inflammation and changes there that lead to cholangiocarcinoma. Additionally, gallstones, chronic gallstones, those can raise the risk for cause chronic inflammation and raise the risk for, perhaps bile or gallbladder cancer. And then some patients have what we call coloducal cysts, which are chronic cysts that form in these bile ducts, as they can in most any duct in the body, and those can create an environment where cancer can develop as well. So, yeah.
And so when you say cirrhosis, we think of cirrhosis as disease of the liver, and one of the common causes of that is alcohol. Have you seen a link between excessive alcohol consumption and the development of these cancers?
Well, certainly, chronic alcohol use can lead to chronic scarring of the liver and cirrhosis over time. I will say, when I say cirrhosis and chronic liver disease, I think more frequently we mean hepatitis B and C chronic infection. Alcohol consumption can raise the risk for cholangiocarcinoma by about 2 to 3 times in retrospective looks. Chronic hepatitis C and chronic hepatitis B, maybe slightly more, maybe 4 or 5 times the risk. And then, one of the things that we haven't talked about a lot, but need to going forward because of its significantly rising incidence, is NASH, or non-alcoholic steatohepatitis, which basically means fat accumulation in the liver, which is drastically growing in this and globally, actually, with the obesity epidemic, and drastically growing as a cause for chronic liver disease. And it's certainly taking over as a leading cause of not only cholangiocarcinoma, but hepatocellular carcinoma, which is another type of liver cancer.
So we're learning more and more about the coronavirus and how it affects different organ systems, for example, the heart, the lungs, the brain. Yeah. Have you seen it affect the liver?
I don't know if I can answer that question. I haven't seen too many coronavirus patients, but I have not seen, at least we don't really know whether coronavirus can chronically affect the liver, right? So if there was a situation where the virus causes changes that are ongoing chronically and cause chronic inflammation in the liver, then that would be a situation in which, certainly it could raise your risk for bile duct cancers.
Okay. And so let's talk about the symptoms. What would a patient, how would they feel if they're developing this? Because we talked about the earlier the detection, the better chance or the better prognosis. So what symptoms may a patient be experiencing?
Yeah, so I think, part of the problem here is the liver is generally very resilient. And so a lot of patients won't have any symptoms when they have, maybe very small tumors. Most commonly, patients will have symptoms that relate to obstruction of the bile ducts. And so those can happen, that can happen within the liver, it can happen outside the liver, the gallbladder for sure. So yellowing of the skin, otherwise known as jaundice, or the whites of your eyes, a lot of itching, which is caused by a higher level of the bilirubin pigment in your blood, and that's very, can irritate the skin. Lighter colored stools, even white colored stools, otherwise known as clay colored stools, darkening of the urine. These are all symptoms of bilirubin backing up into the bloodstream. Otherwise, pretty non-specific symptoms, more fatigue than normal, maybe some abdominal pain, usually on the right side, although it could be anywhere, unintended weight loss. In terms of gallbladder cancer, there's a percentage of patients who have a gallbladder tumor that's diagnosed just simply when they go in for to have their gallbladder removed. They go in with symptoms of a gallbladder infection. The surgeon goes in to take that out, and pathologically you find a tumor, or the surgeon finds a tumor, and has to decide what to do at that point. And that's incidentally noted gallbladder cancer. So that can be particular to gallbladder cancer in itself. But
so given how vague these symptoms are, what tests, how do you diagnose these conditions?
Yeah, so a lot of patients will come in saying, my doctor found that my liver tests were elevated, and this is something that's routinely done, usually during a routine physical or follow-up exam by your primary care physician, perhaps. And then usually what we'll do is get a CAT scan, right? Everyone who comes with abdominal pain to the emergency room usually gets a CAT scan or an ultrasound of the abdomen, and that will show signs of a mass in the liver. A lot of times we'll get MRI, at least in our practice here. MRIs can help to delineate, the tumor relationship to the bile ducts, and critically relationship to blood vessels, with all of the blood vessels within the liver, which are important when we're trying to decide whether something can be taken out surgically or not. It also will identify very small, you also want to identify very small, what we call satellite lesions, which happen very frequently with bile duct cancers. So you can have like a main tumor in the liver, but then there are satellite lesions elsewhere that we really want to know about. Frequently we see a main tumor, and then we see satellite lesions elsewhere in the liver. And we want to know that. That's important when we're trying to plan for different therapeutic options that we might have, like surgery or other things.
Why is that important to diagnose these satellite lesions? Are you talking about metastases or just lesions elsewhere in the liver?
They could be considered intra metastases within the liver, or they're other separate tumors, right? So remember that bile duct cancer is developing in this environment that's pervasive throughout the liver, presumably, right? Chronic inflammation across the liver, and that environment's present all over the bile ducts, and so you could get separate tumors that develop, all over the place, or they're intrahepatic metastases. But it's important to know that, because if you see only one small tumor here, and you don't see the satellite tumor over here, and then you go and try and take this main tumor out surgically, for example, then certainly that other tumor is going to start to grow after surgery, right? Whenever you stop any adjuvant or post-operative therapy and that sort of thing, so that person's at higher risk. We want to know the totality of the disease as best as possible. So that will include getting a CAT scan of the chest as well, to make sure that there's no spread of the disease to the chest also.
So Dr. Mody, you touched upon some of the treatments, surgical interventions. Can you talk about the sort of spectrum of treatments that a patient could be expected to have?
Sure. So surgery and taking out all the disease is the ideal way to treat this tumor, and really the only way to offer the patient the potential for cure. And as we said before, it's unfortunately not common enough that we find these situations where we see a tumor that can be taken out right away. In addition to surgical resection, Mayo Clinic did pioneer the advent of transplantation, or liver transplant, for particular cholangiocarcinomas that occur where the bile ducts come down, and called the hilum of the liver. So it's a particular location where you can get these tumors, and we have a pre-operative treatment where we apply chemotherapy and focused radiation, and then put patients on a maintenance chemotherapy that goes on until they get their liver transplant. And that's been life-changing for a lot of patients with this particular bile duct cancer. Short of surgery, if surgery is not an option, then depending on where the disease is and how extensive it is, we can employ chemotherapy or systemic therapies, which I'm sure I'll probably talk about in a couple of minutes. But in addition to that, radiation, and there are different forms of radiation that we can do. We can do radiation that comes from outside the body, the traditional radiation that people hear about, or we can do radiation that is deployed on little glass beads or resin particles that we can deploy via catheter to the tumor directly. and deliver high doses of radiation that way. So a lot of different things we can do, but sometimes that treatment leads to significant response that enables the patient to then go on to have a surgery to take it out, and that's fantastic when that happens. And sometimes it doesn't.
And what about proton beam? Has that had any role in the treatment of these liver cancers or bile duct cancers?
I think that's still being ferreted out. There are pros and cons to proton, and I'm not a radiation oncologist, so I'm not going to wax poetic about that. But certainly there could be a role, but it's something that's being more explored. Finding ways to, I think the crux of that question is really, how can we find a way to get more radiation to that tumor and spare normal liver? That's the ideal situation, and so we can do that potentially with proton. We can also do that with the beads and very particular mapping and dosing that way as well.
So let's talk about what Mayo Clinic is doing for treatments. You touched upon the surgical sort of nuances. Tell us what Mayo Clinic is leading in terms of treatments for these type of cancers.
Well, so I think what we try to do best here is a multidisciplinary approach with faculty who are truly all in and focused on cholangiocarcinoma. And so we have surgeons who are that way. We have medical oncologists like myself who do the same thing. We have radiation oncologists who are focused on liver cancers, and interventional radiologists too, who are passionate about this topic. And then on the also part of that team are folks in the lab, and we have a number of labs at Mayo that are doing groundbreaking research on the immune environment of cholangiocarcinoma and bile duct tumors, targeted sort of signaling pathways to take advantage of, and the true nitty-gritty biology of how these tumors grow and survive, and how we can target that. Also, how can we model the disease better so that we can evaluate treatments better? And we're doing work down here across the enterprise on modeling it in specific tiny little what we call microcancers, and being able to test different things that way, and hopefully innovate treatments outside the patient before we get into a clinical trial.
So given this sort of multidisciplinary innovative type of treatments, if I was a patient and I wanted to get, for example, a second opinion or learn about the latest treatments, how does one go about doing that?
Yeah, so I think in terms of bile duct cancers, as a patient, it's incredibly important to have the opinion or have the evaluation of a team that sees a lot of this disease, because as we said, it's not very common, and many oncologists across the country will only see a couple over the course of their career. And so I think it's incredibly important that patients at least get the opinion of someone who sees a lot and can help to develop a treatment plan, hopefully an innovative one that can be employed as a team, and that includes their local oncology team for sure. So there's lots of patients I see from all over the country that I partner with their oncologist to deliver particular chemotherapy or targeted therapies, and we have touch points back and forth regarding repeat imaging and all sorts of stuff that we can participate in.
And I think that's good for patients to hear, that they can have their treatment close to home, but still be connected with Mayo Clinic.
Yeah, I mean, there are lots of cancers, and bile duct cancer is one of them, where we know there are survival advantages if you have the involvement of a dedicated, specialized, multidisciplinary team. And again, we're not trying to exclude anyone, right? We're just trying to offer our opinion and our expert recommendations, because cancer is moving so quickly now. There's so much happening in every disease that it's not possible for one, oncologist who treats everything, a general oncologist, to know the nitty-gritty about every single one. And so we're just here to help and provide, that updated, nuanced information to each particular case in a personalized way.
So Dr. Mody, with as you mentioned, the rapid developments that's happening, how has that changed the prognosis of this condition?
Yeah, good question. So I think cholangiocarcinoma and liver cancers in general is one of these things where there's been a lot of development over the last couple of years, and it stems from biology and learning biology and genomics particularly. So a few years ago, several years ago, when we were able to finally, sequence the tumor genome and learn more about the biology of the disease from the genetics, we learned a lot about cholangiocarcinoma. So we learned primarily, one of the biggest updates is that, we learned that there are particular genetic alterations that drive these tumors, and they differ between the different subtypes. So intrahepatic cholangiocarcinoma differs from extrahepatic cholangiocarcinoma, differs from gallbladder, and the genetics differ among these three. And those genetic alterations have lent themselves to different new therapeutic options that patients did not have before. And the pharmaceutical industry has followed suit and done research and development and developed drugs that are now on the market, and much more to come, to offer patients significant responses and disease control. So it's really exciting. That's one of the biggest things. So, every patient with bile duct cancer should have their tumors genetically sequenced, which is easily done now. And so they know the genetic nature of their disease.
So as we talk about variations and genetic variations, have you noticed healthcare disparities and how that affects both the diagnosis and the treatment and prognosis of patients with liver or gallbladder cancer?
Yeah, I mean, I think that's a great question. I think this, the healthcare disparities that exist for pretty much cancer in general and cancer care, apply to bile duct cancers as well. In the United States, the incidence of cholangiocarcinoma is higher in older folks, older than 45, 50 years old, than it is for younger, although it's rising for younger folks. It's higher for Hispanic individuals compared to non-Hispanic individuals. And the 5-year survival is worse for both of these populations. There's worse overall survival rates reported for African Americans, American Indians, and Alaska Native groups as well, that we've seen in large database studies. And like I said before, globally, there's geographic variations. And so there are differences in delivery of healthcare that can affect, in general, that can affect the treatment that folks at different groups might have access to. And we're definitely trying to change that by reaching out to the community and providing services to them to get them the knowledge that they need to be their own patient advocates, hopefully, in asking for this stuff. So for one example is, the genetic mutations, and a number of academic institutions, including ours, have, worked with the Cholangiocarcinoma Foundation, which is a patient advocacy group that's done a huge campaign on how mutations matter in this disease, and really tried to educate the cholangiocarcinoma patient population. And that hopefully goes out to groups of all kinds, all over the country, all over the world, actually, so they can advocate for themselves in treatment options that they otherwise wouldn't have,
Yeah, no, that's incredibly important work, and thank you for sharing that with us. So when we have these disparities that exist, what are we doing for screening?
Right, so screening for cholangiocarcinoma, there's not really a single screening test yet. There's obviously a lot of work going on in the field to try and avail ourselves of an easy test. Unfortunately, that doesn't exist. But when it does, it will be incredibly important to get that knowledge out to communities all over the world, and make those tests readily available. All right, that's the second part. You can educate people, but you got to get that test to be readily available to them. But that'll be incredibly important. But from a screening standpoint, right now, there's not really a defined screening test for that. That is one thing that's being worked on here, in particular, in addition to many other places, and trying to find genetic changes in the bile that we can sample endoscopically, or even hopefully in the blood, that signal a very high likelihood that there's a cancer hiding out somewhere, and then to be able to go look for it. So we'll see.
Dr. Mody, anything else that you want to share with us that we haven't touched upon?
No, I think I thank you for the opportunity to talk about a rare cancer, but one that's passionate to a lot of us here at Mayo Clinic, and we're spending a lot of time working on. And we do have a very large NIH grant that's dedicated to these cancers, that's exploring all sorts of really exciting stuff. And so hope to bring a lot more innovation to these patients in the near future.
Well, that's tremendous. We've been discussing gallbladder and bile duct cancer with Dr. Kabir Mody, past co-chair of the Hepatobiliary Disease Group at Mayo Clinic Cancer Center. Dr. Mody, thank you for being with us today.
Thank you very much.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on Podcasts. Thanks for listening, and be well. We hope you'll offer a review of this and other episodes when the option is available. Comments and questions can also be sent to Mayo Clinic News Network at mayo.edu.